Give you guys a heads up on the free responses, the ABGs. Remember, if you don't format your answer just like my answer, it shows wrong. Make sure I give you points for it though. If you are correct, even though it shows wrong, check out the points in the top right, just to make sure. So I try to, I ran through everybody's. It looked pretty good. Oh, it's all of the pets. I'm feeling better, Lita. I don't know. It's weird, y'all. Like, just COVID is no joke. I can see why people are dying from it. Even like, shoot, man, I got vaccinated. I was hoping to get my booster shot, but Mother Nature's like, hey, you want a fucking booster? I'll give you the best one there is. Man, I haven't been sick like this in so long. Usually maybe a cold or the flu is one day for me. I'm kind of a person where I just, ain't got time. Saturday was just spent hibernation. My body's still sore from either the virus or just like not being able to move. So that sucks. But today I actually have a voice and I'm not so foggy headed. So that's nice. But like, y'all stay safe. Y'all stay healthy. Wash your goddamn hands. Don't go through this. Just don't. Yeah. All right. So today we are going to jump into pulmonary path. So when respiratory kind of goes wrong. So just heads up, your quiz tomorrow. Remember, your quiz tomorrow will be pulmonary phys and pulmonary path. So last Tuesday's lecture and this lecture. I know that sounds like a lot. I know you guys got exam brain, so I'm going to give you, like, here's me throwing you the bone. Your quiz tomorrow is 70% pulmonary phys. Okay, so the lecture that we've already had, that will be the majority of the questions for the quiz. Any questions from this lecture is superficial, really way superficial. Okay, I'll try to give you a couple of hints here and there. Okay. All right, so pulmonary path. Here we go. All right. So first part, it's going to be kind of pretty straightforward. First part's just a little bit of vocabulary. Dyspnea. Anybody remember what dys means?
Difficulty.
Difficulty, abnormal, uncomfortable. Pnea means breath. Okay. So uncomfortable breathing, cool. A form of dyspnea is orthopnea. Ortho translates to position. Okay, so orthopnea is when somebody has difficulty breathing while usually laying down. Why would I take, for example, me, because I'm dying. Why would I have difficulty breathing while laying down?
If you're laying on your back, it doesn't allow your lungs to expand fully.
So part of it is maybe my lung expansion for sure.
The fluid is like, words don't work.
Yeah, it's like sitting on top of the lungs. Yeah. So what I'm going to say here is fluid and mass on lungs. On lungs and diaphragm. So one thing I'm really thankful, you guys said, is because I'm fat. It's the truth, okay? Because I'm heavy, all of that weight pushes down on my respiratory tract, okay? So obesity can do that. The other one is women with really large breasts, memories. That extra weight can actually depress the ability to breathe as well. So a couple reasons. Paroxysmal nocturnal dyspnea. Hint, hint, nudge, nudge. All you need to know is, when does paroxysmal nocturnal dyspnea happen? All you need to know is, what time of day does this happen? Anyone?
At night.
Done. Yep, this happens at night. So difficulty breathing at night. Not really going to get into it. All you need to know is when does it happen? Okay. If you're curious, LV, that stands for left ventricular failure. We'll talk about that when we hit the heart. So that's why I'm saying don't worry about it for now. All right, so here are the different abnormal breathing patterns. Kind of be familiar with this. Heads up, there's a difference between tachypnea and hyperventilation. Okay, so this is going to be more of a kind of a thing with health assessment as well, because Lindsay's going to be going towards this. Because you guys are on HEANT right now, right, for health assessment. Isn't it nice you know your cranial nerves? So let's just kind of roll right into this slide right here. Just I kind of made this table here to kind of help things out. So definition wise, these are the translations. So starting with tachypnea, what does tachypnea translate to?
Rapid breathing.
So yeah, fast, and then pnea is breath. So you can say rapid breathing, that's fine, or fast breath. Versus bradypnea, that's slow breath. And you're going to see why I keep emphasizing the term breath for pnea here. Apnea, A, without breath. Okay, so I want you to think about tachypnea, fast breath. If you had to move your breath quickly, that means you're going to have a high respiratory rate, but a low volume. So you're breathing quickly, but you're not moving a lot of air. It's fast breath, not lot of breath. Okay. So actually, let me, instead of saying slash, let me say high respiratory rate and low volume. You guys see what I'm kind of hinting at here is this is not hyperventilation. Okay. When we see someone kind of doing this tachypnea, we think they're hyperventilating. That's not correct, because hyperventilation, so hyper means elevated. You guys remember ventilation, your VQ ratio? What did ventilation mean?
Gas exchange.
Yes, yes. I'm going to say moving air. So with hyperventilation, you're increasing the amount of air that you're moving. This is the big difference between tachypnea and hyperventilation. Yeah, you're increasing your respiratory rate, but here you're also increasing your volume. So again, both of them describe an elevated respiratory rate. Hyperventilation describes you're moving a more air. Hyperventilation, you're moving more air. Versus tachypnea, you're moving more breaths, but less volume. Okay. Let me be completely honest here. With the possible causes, not going to test you on it. Okay, that's going to be more for med search. This is just to kind of give you some examples for some context here. So with tachypnea, you might see that during kind of like hypoxia, when someone's hypoxic. Kind of think about when you hold your breath for too long underwater, you pop up. What does the breath look like when you come out and you finally get that gasp of air? Okay, so that's the tachypnea. With the hyperventilation, this is what you kind of see with exercise. Oops, sorry, it was supposed to be green. Exercise. Slash DKA. We'll talk about diabetic ketoacidosis. So tachypnea, this is like when somebody's freaking out because of stage fright. It's very short, very rapid breaths. Versus hyperventilation, this is your breath after you run a bunch of sprints. Can I see how one is moving more volume? Okay, so just heads up, that's going to show up in health assessment there. Bradyapnea, something that would slow somebody. So let me switch to blue here. With bradyapnea, decreased respiratory rate. Okay. And there's no change in the volume. So you're still just keeping your tidal volume. Okay. This is what you see with increased intracranial pressure or opiates. Okay. When somebody overdoses on opiates, their breathing slows down. Okay, but they're not taking smaller breaths. They're not taking larger breaths. They're just taking fewer breaths. Okay, apnea, that's kind of self-explanatory, no respiratory rate. What causes a person not to breathe? Death. Hypoventilation means we're moving less air. Okay. Decreased respiratory rate. But here, remember the big difference between ventilation and apnea is changes of volume. Okay. Causes could be like asthma. The way I kind of think of hypoventilation, imagine like you got some really bad pain. I think of Family Guy, like, you know, when Peter Griffin stubs his toe and he's on the ground, like holding his shin, like, that's the kind of breath pattern I think of hypoventilation. Okay. Kussmaul respirations, Kussmaul. So this is kind of a weird one where the Latin doesn't really help us. Kussmaul is just another way of saying hyperventilation. Okay. So what we wrote for hyperventilation would be the same thing here. So Kussmaul's respirations, you can see with exercise, DKA as well. Why would Kussmaul's respiration help out with acidosis? If somebody's acidic, so yeah, hey, guess what? Pulling in stuff that you just had a test on. If somebody's acidic, how would Kussmaul's respirations help? How would that allow them to compensate?
You're expelling CO2, which is acidic, trying to balance out the pH.
That's perfect, exactly. You're trying to expel CO2, right? You're trying to get rid of that acid. Cheyne-Stokes. Now there's plenty of different ways to pronounce it. I believe it's like also pronounced Shane-Stokes, whatever. I call it Cheyne-Stokes because it sounds purposely wrong. Whatever Lindsay says it is, you go with that, okay? With Cheyne-Stokes, you have intermittent apnea. You have intermittent apnea. Okay. Causes, these are known as your, ooh, damn it. Your near death respirations. Near death respirations. And there's a slide coming up with a bunch of pictures that'll kind of help us out. Again, for this slide here, know the name. I think the definition helps, like the Latin, and then the symptoms. Don't worry about the causes. The causes are just to help you with some context. Okay. So Q small, right here you have some tidal volume, and then you have these sudden spikes. Okay, Q small, again, that's hyperventilation. You're moving air and you're increasing your respiratory rate. You see that with exercise and DKA. This is Chinese Stokes, where somebody is flat and then they gasp and then they flat and then they gasp. Okay, so with Chinese Stokes, what ends up happening is as I am dying, my brain is shutting off, right? If my brain is shutting off, no one's telling me to breathe. Now I have CO2 receptors in my body. They understand that CO2 is building up. This is a reflex. This is what causes the person to, but then the brain isn't driving anything, so it goes back to apnea. So this person can stop breathing anywhere between 20 seconds to 2 minutes and then start gasping for air. This reflex, this gasping, again, is just dying reflexes. Okay, engine's running, but nobody's home. Does that kind of make sense? So again, with Chinese Stokes, that's why near death pattern, because the brain is pretty much done. Okay. Tachypnea, fast breath, but lower volume. Bradypnea, slow breath, no changes in volume. Biots, you do not need to worry about. Okay. That's more MedSearch 1. That's just if we have some issue with the brain stem causing this irregular breathing pattern. Okay. So hypoventilation, decreased respiratory rate, and no change in volume. Oops, sorry, that's Nia. My bad. Okay. Yeah. Decrease in volume. Sorry. I'm a little cloudy still. So if somebody is hypoventilating, they're becoming hypercapnic. If somebody is hypoventilating, what is building up inside their body?
Carbon dioxide.
Elevated CO2. Capnia means carbon dioxide. What about the other side of the coin? What about their oxygen levels? If someone is becoming hypercapnic, what is happening to their oxygen levels?
They're decreasing.
You have hypoxia and hypoxemia. What's the difference between hypoxia and hypoxemia? You should actually know now.
One is in the blood and one's in the lungs.
Close, close. Hypoxemia, low oxygen in blood. Oxia, that describes low O2 in the tissues. So yes, lungs being part of it, but means muscles, other tissues, heart, lungs, organs, brain. Okay. So is it possible to have a patient with hypoxia, but no hypoxemia? So let me put it this way. Is it possible to have cyanosis, even though you have an O2 sat of 98?
Maybe if you had like a blood clot.
Maybe if you have a blood clot, awesome. So what I'm getting at is you can still have oxygen in your blood, but we can have difficulty moving it to the tissue. So it could be a blood clot. It could be, maybe they don't have enough blood. Great. Hyperventilation then, on the other side of that, increased respiratory rate, increased volume. That causes hypocapnia. Low CO2. How would you describe oxygen in a hyperventilating patient? Have you guys ever heard of the term hyperoxia or hyperoxemia? No, because it doesn't exist. There's no such thing as hyperoxia. You can't have too much oxygen. You can't have too much oxygen in your blood. So what I'm getting at is be careful. Okay. We really only care if oxygen is low. If somebody has adequate oxygen, you never say hyperoxia or hyperoxemia. Okay. A cough is a protective reflex that is dependent on inhalation. So let's just say you have a patient with a lot of phlegm because they're getting over COVID and it's fucking gross. Sorry, I'm a little bitter. And you want your patient to cough. What instruction would you tell them?
Sometimes if you take a deep breath, it'll force you to cough.
Exactly, exactly. If you want me to cough this up, you need to inhale. The deeper the inhale, the stronger the cough, right? Perfect. Abnormal sputum sucks for me, helpful for you. If I start coughing up blood, hemoptysis, this is bloody sputum / phlegm. If I start producing hemoptysis, I'm coughing up blood. What does that tell you as a nurse? Why is that helpful as a nurse? What does that indicate to you? Where there's blood, there's
Trauma.
yeah, trauma or / injury, perfect. And if I'm coughing up blood, where's that trauma? Where's that tear? Where's that injury? Which
In the
tract?
respiratory tract.
Yeah. So hemoptysis indicates bleeding at the respiratory tract. Awesome. This is a little side note here. Hemoptysis is not hematemesis. Hemoptysis is not hematemesis. Hematemesis is bloody vomit. Okay, if a patient produces hematemesis, where's that bleeding?
In the GI tract.
There you go. Okay. All right, so thankfully you guys have already seen this in health assessment. It's going to go by quickly. 2 types of cyanosis, what are they? Or have you guys seen this yet in health assessment, or am I? No, not yet. Okay, I'm sorry. Let me know if I'm talking nonsense, okay? So with cyanosis, there are 2 types. You have central versus peripheral. Central versus peripheral. Okay. So with central cyanosis, what is turning blue?
Like your lips, your stuff in the trunk.
Yeah,
Lips.
I'm gonna say lips / core.
Yeah.
Mhm. You might see it in the conjunctiva, is what Lindsay's going to introduce. Versus peripheral, then it's going to be toes / hands. And which one's worse?
Central.
Why?
Because it's not as big of a deal if you're not perfusing to your hands and toes as it is if it's just showing problems with the respiratory system, like directly.
Mhm. So with central cyanosis, your organs, your lungs, your heart, your brain are not getting enough blood compared to your hands and toes, right? So worse because trunk organs at risk. Okay, clubbing. So clubbing, I'm just going to kind of write down the definition. This is the distal digits becoming bulbous and enlarged. Okay. Indicates prolonged hypoxia. And the weird thing is development is usually painless. So in clubbing, the distal digits become bulbous and enlarged. Your fingertips almost look like they're starting to get swollen. I got some pictures coming up. Okay. If these fingers start becoming bulbous or enlarged, it means that blood hasn't been getting down there, i.e. ischemia, which means hypoxia. Okay. So what population voluntarily puts themselves in a state of hypoxia? Voluntarily puts themselves in a state of hypoxia, usually, 10, maybe 5-10 times a day.
Smokers.
Smokers. So you can see smokers with clubbing. The weird thing about it is you don't know it's actually happening until it's already progressed to a certain point. Okay. So here we go. Cyanosis. So this is the picture in the textbook that you guys use for clubbing in health assessment. Have you guys talked about clubbing yet? A little bit. It's kind of like talking about the angle of the fingernail to the nail bed. I didn't really get that. So, hey, here you go. Here's some pictures of clubbing. You guys see what I'm saying now with this bulbous enlargement? Okay, again, it's not painful. It just shows prolonged hypoxia. Okay. Now, I know it's a Monday and you guys just took an exam, so bear with me. Take a close look at this third picture here. Do you guys see evidence of clubbing? Her hands are in the air.
Can you shut up? That was such a bad joke.
Happy Monday, everybody.
I love a good dad joke.
Yeah, the power I wield. Like Greg was looking at it just like, nah, man, I'm good. Lita already had her palms buried on her face. You guys are too trusting. All right, hypercapnia we talked about already, too much CO2. Hypoxemia versus hypoxia we've talked about already. This is in blood versus in tissue. Okay. Shunting. Do you guys remember about shunting? Might seem like a lifetime ago though. Okay. What do you guys remember about shunting?
Usually occurs from like a compromised alveolar sac or blockage.
Perfect. Triggered by hypoxia. Okay. Do you guys remember there was like a saying associated with shunting?
Good now, bad later.
Good for now, bad for later. Absolutely. Good for now, bad for later. Okay. And shunting will come up a little bit later here. Acute respiratory failure. So anytime you see failure, there's usually an organ kind of attached to it. So you might hear of cardiac failure, cerebral failure, pulmonary failure. Respiratory failure, we know it's the lungs. Okay. Now it is acute versus chronic. Therefore, it is sudden. So acute respiratory failure translates to sudden lung failure. Okay. Or a sudden inability to exchange gases. Pulmonary edema, water in the lungs. Okay. Oh man, this picture looks familiar, doesn't it? Why? So let's talk about pulmonary edema. With shunting, we were diverting, actually, yeah, let me say diverting blood to a good alveolar sac. That saying was good for now, bad for later. Good for now, bad for later. Why was shunting good for now? What did it help me do in the moment if I diverted blood to a good alveolar sac?
It increased your VQ ratio.
Yeah, nice. Increase the VQ ratio or the I ran out of room, oxygen saturation. Okay. But what was so bad about taking blood from two vessels and jamming it into one?
It doubles the blood pressure at the alveolar sacs.
Absolutely. That increased my capillary hydrostatic pressure. Okay, so my capillary hydrostatic pressure, like we've been talking about, it's now doubled. It went from 100 to 200. Okay, my lymphatics, they only drain 10%. My reabsorption only drains 90%. So how much do I have left over in this space?
100%.
Yep. So is that a lot of edema? Yep. So what I'm trying to get at here is, hey, look, this stuff is still around. Bad for later, increased capillary hydro. That's going to lead to edema at the lungs. Okay. So putting it all together here, shunting increases your VQ ratio, awesome, but that also increases your capillary hydro. If you increase the capillary hydro at the lungs, that leads to pulmonary edema. And recapping, what caused the shunting?
Hypoxia.
Perfect. Okay, so we're going to be building on this pathway a little bit here, but this is going to be kind of like the key to pulmonary path. Okay. So just kind of keep on the right-hand side in green, keep that in mind because we are going to elaborate on it. Okay. Aspiration is kind of self-explanatory. Fluid and solid particles into the lungs. You inhale things that shouldn't. Atelectasis, this is a partial lung collapse at the alveoli. Okay, so atelectasis is where your alveolar sacs collapse. Not the entire lung, but the little air sacs. Okay, there's two types of atelectasis. Compression atelectasis, this is going to be alveolar collapse due to some sort of physical force. And I got pictures for these. Okay. Absorption atelectasis is going to be due to what we call nitrogen washout. If you guys remember, surfactant had how many functions to it? 4 functions. One of them was to keep your alveolar sacs open. So if you have surfactant impairment, your sacs are going to collapse. All right, so compression atelectasis. So in this case, we have a tumor, and on this side, we have some sort of fungal growth. If you notice, area in between, that airway is being pinched. So this middle lobe is going to collapse. What about the top and bottom lobe? Are they going to stay open? Well, they should, because they're still getting air. Okay. This is what I mean by a partial lung collapse, where only part of the lung collapses, not the entire thing. Okay. So with the compression atelectasis, whether it be a tumor, whether it be scar tissue or fungal growth or a bean sprout, we're closing that airway, causing just that portion of the lung to collapse. Okay. Absorption atelectasis. This is caused by nitrogen washout. Nitrogen washout. Okay. Now, you don't need to know these percentages. This is just illustrating a point. The air that we breathe is give or take about 22% nitrogen, 27% oxygen, and 0.003%. It's a little higher now, CO2. Again, you do not need to know these percentages. Just trying to illustrate a point here. The air that you breathe is primarily made up of what? What is the air that we primarily breathe made up of?
Nitrogen.
Nitrogen. So right now inside of your lungs, you have a bunch of nitrogen. Actually, let's just do it on one side. Okay. What do we use nitrogen gas for in the body? It's the answer y'all are giving me right now.
Nothing?
Nothing. We don't use nitrogen gas for anything. So if we have a bunch of nitrogen in our lungs, does it go anywhere? It stays in there. In fact, nitrogen is what keeps your alveolar sacs inflated. If I bring oxygen down, where does oxygen want to go? Into the blood or into the environment?
Blood?
It wants to go into the blood. CO2. That wants to go out. Nitrogen stays behind and keeps things inflated, okay? What ends up happening is if you, let me say causes, inhaled anesthesia or 100% oxygen. If I go for a procedure and I have to inhale anesthesia, okay, let's say I inhale, and let's do oxygen to make it a little bit easier. If I inhale nothing but oxygen, that's going to push all of my nitrogen out. So the only thing that's left in my alveolar sac is oxygen. What's going to happen to all of that oxygen?
It goes into the blood and then the sac is going to deflate.
Yahtzee. That's why we call it nitrogen washout. Okay, so really this is going to be more of an issue if you're going to get into anesthesia, but we can't have someone inhaling anesthesia for too long or we're going to wash out their nitrogen. Okay, so absorption atelectasis is caused by inhaled anesthesia or 100% O2. It's this idea of this nitrogen washout. Okay. Bronchiolitis, don't overthink this one here. Itis, bronchial. So we know itis means inflammation of what structures? It says small airways, but which small airways specifically?
The bronchioles.
And what made bronchioles unique?
Smooth muscle?
They had that smooth muscle. So if your bronchioles become inflamed, that smooth muscle is going to kind of pinch down, difficulty breathing. You can see this in RSV. Let me say, I will not test you on this, but this will show up in PEDS. This is respiratory syncytial virus. Okay. Again, I'm not going to test you on RSV. All you need to know for me in my class, bronchiolitis, inflammation of the bronchioles, you can't breathe. Okay. But RSV is kids. So bronchiolitis obliterans. So we're still talking about inflammation of the bronchioles. What's new is obliterans, to obliterate something. Heads up, guys, when you obliterate something, it doesn't mean blowing it up, okay? Your lungs are not exploding. When something becomes obliterated, it means obstructed. So bronchiolitis obliterans is when your bronchioles become obstructed during inflammation. So let me kind of think, let's kind of like think about this big picture wise. If my bronchioles become inflamed over and over and over and over several times, each time I become inflamed, what do I start leaving behind?
Scar tissue.
Scar tissue. Bronchiolitis obliterans is a late stage fibrotic disease, i.e., your bronchioles start becoming filled with scar tissue. Your bronchioles start becoming filled with scar tissue. Therefore, is this reversible? No. Scar tissue doesn't go away. Okay. Now, bronchiolitis obliterans you might have heard as popcorn lung. The popcorn lung. How on earth did it get that name? Workers who used to make microwavable popcorn. Now, look, if you eat microwavable popcorn, I ain't judging you. All right. I enjoyed it. I enjoyed it myself. What they used to do was there was a butter flavorant that they used to use to make your popcorn taste like butter without using real butter. Okay. When you inhale that, that caused inflammation in the lungs. Workers at these popcorn factories wouldn't be inhaling this buttery flavorant over and over again, causing their lungs to fill with scar tissue. That's why we call it popcorn lung. Nowadays, microwavable popcorn does not have this ingredient anymore, thank God. But we're actually still seeing rises of cases. We're seeing an increase in cases of bronchiolitis obliterans. Anybody know why?
From vapes.
Vaping, yeah. In the vape industry, okay, there's plenty of different flavors. Do you want to smoke marshmallows? You can. Do you want to smoke Granny Smith apple pie? You can. You can. There's so many crazy flavors. Some of them actually use this butter flavorant that was banned in the popcorn industry. Okay, so hey, just saying, if you're gonna vape, just don't smoke butter. That's just weird. Don't need to worry about that last point there. Okay. All right, pneumothorax. Let me kind of see where we're at. All right, we'll get through the pneumothoraxes and then we'll take a little break, okay? Pneumothorax. Anybody remember what pneumo meant?
Lungs.
Kind of. It's in the lungs.
Air.
Air.
Lungs.
Yeah. Thorax in the chest. All right, so pneumothorax means you have air in the chest. So what? I mean, come on, you breathe anyhow, you have air in the chest, right? The issue with a pneumothorax is air in the chest outside of the lungs. Outside of the lungs. Okay. Now, in an open pneumothorax, this is the analogy I use. This is like getting stabbed with a straw. Stabbed with a straw. Okay. So, take for example, let's just say Lita has had enough of my dad jokes. She can't take it anymore. So she's going to stab me in the chest with a straw. Now, Lita, you were raised properly. You're not rude. You leave the straw in my chest. Thank you. So here's your lung, or my lung. Okay. Now I have this open straw sticking out of my chest cavity. What two pressures are touching now? What two pressures are in contact with one another?
Barometric and alveolar.
Not alveolar.
The whatever's plural, PIP, that's one.
PIP, there you go. Barometric and PIP are now touching one another. Because they're touching one another, there's no difference. I.e., what I'm getting at is, in an open pneumothorax, PB is equal to PIP, or 0. PB is 0, PIP is 0. They are both 0 in an open pneumothorax, okay? I go to the hospital, they stitch me up. Thank God I can breathe again. Okay. Meredith is like, not on my watch. She's going to straight up stab me with a knife. She saw Lita's mistake. So she takes it up a notch, stabs me with a knife. This time she takes the knife with her. Jerk. There's my lung. The issue with being stabbed with a knife is this creates a one-way valve. This creates a one-way valve where air can now go into the chest cavity, but it cannot go out. So, which pressure is changing then? In a tension pneumothorax, which pressure is changing? Which pressure is going up?
PIP.
PIP is now going to increase. PIP is now positive. In fact, it's going to get to a point where PIP is so positive, it's larger than PA. Okay, and I got a couple of videos that'll kind of help tie all of this together here. Spontaneous pneumothorax, don't worry about it. It's pretty rare, but it is exactly as it sounds. You're walking around, you run into the wall, and then all of a sudden your lung just collapses. It's caused by blebs, these little air pockets that you grow in your lungs. It's a genetic condition. You never know you had it until they popped. Secondary pneumothorax, a lung collapse due to something else. Okay. So it could be trauma, like somebody punched me in the chest hard enough, my rib punctured my lung. It could be surgery. Just secondary pneumothorax just means due to something else. Okay. So in a pneumothorax, again, there's air in the chest cavity. Uh-oh, big problem. And in a pneumothorax, we're seeing a whole lung collapse. Okay. Why is my whole lung collapsing with a pneumothorax?
Because the PIP pressure is more than the alveolar pressure, so it compresses it down.
Ah, that's the tension, absolutely. Just in general though, with a pneumothorax, you nailed it. I'm just gonna say PIP is not negative. Okay, that's why the whole lung's collapsing. Okay, so a little video.
Hey everyone, welcome to Marvel Medicine. This next part is part 2 on respiratory physiology. Now, with expiration, the diaphragm just relaxes and moves back up. That causes the intrapleural pressure to become less negative, so more on the positive side, but not positive. What does that do to the lungs? The big negative vacuum effect lessens and the lungs don't want to stretch out as much anymore, so they shrink and contract back. That also contracts the alveoli inside the lung. When they contract, the pressure inside the alveoli becomes positive, and the air then goes from the alveoli to the trachea out of the mouth. So, the concept they love testing you on USMLE Step 1 is about pneumothorax. Let's take our lungs, chest wall, diaphragm, and negative intrapleural space, keeping our lungs inflated. Everything's normal. And now let's poke a hole into the chest wall through the interpleural space. What does that do to the interpleural pressure? It becomes 0. Why? Because now the atmospheric pressure outside the chest is connected to the space inside the thorax, which is 0. Now that the interpleural
Do you guys kind of see the analogy here when I was talking about being stabbed with a straw?
space isn't negative anymore, what happens to the lung? It's not getting pulled out anymore and it collapses. That, my friends, is a pneumothorax. Does that make sense? What you would see is the lung collapsed on a chest x-ray. What does that look like? Basically a black area being really small on one side, like this. What's a tension pneumothorax and how is it different? So remember where we poked a hole? The next time you have chicken at home and are about to cook it, I know this is kind of crude, but take a knife and stab it through the skin. You notice how there's a little flap of skin? The same thing happens when the human chest gets pierced, like a stab wound. There's a flap. Well, what does that do? It kind of acts like a one-way valve. It sucks air into the chest cavity, but doesn't let it out. Just visualize that. Air going in, but not coming out, little by little. That creates more and more pressure inside this intrapleural space. What does that do to the lungs? It really pushes them, and it can accumulate so much air and pressure in this cavity that it pushes the structure next to the lungs, which is the heart. Like this. If it pushes the heart, what would that do to your
So that's going to get into kind of what we're going to get into is how it affects, how your lungs affect your heart. Does that kind of help you guys visualize what's going on with the PIP being more or less negative? Okay. So this is a tension pneumothorax. This isn't a kind of an analogy, so this isn't perfect. But here we have a goat's lung inside of the bag. Okay, the bag representing your pleura. What I want you guys to notice is pay attention to how much the lung inflates over time. Pay attention to see how much that lung can actually inflate.
Plastic bag.
Pleura. Okay, here we have some goat's lungs and a heart in there. It's intubated. We're in a plastic bag to mimic the pleura. Right. Now this lung does have a little hole in it. So we have a pneumothorax. It's just around the side, just a little wee punctured lung. I'm bagging a bit faster than we normally would. But as you can see, the air is escaping from the lungs and into the pleura. And little by little, the bag is getting filled more and more.
So let's just to pause it really quick. Do you guys see any difficulty with that lung inflating? It's still inflating all the way, but what do you guys notice is happening?
The bag is also inflating.
The bag is also inflating, i.e. PIP. So as the lung inflates, PIP is becoming more and more positive. It's going to get to a point where it's so positive, there's so much pressure in the bag, the lungs can't fill anymore. Okay, so this is what I was telling you, when PIP becomes too large, it becomes bigger than PA, your lungs won't inflate anymore.
So currently there's no pressure against the lungs that I'm feeling. It's just as easy as it has been. It's starting to get harder to bag it now. It's getting really hard to bag it now.
You guys see how that lung's not inflating anymore? Okay, that's now PIP is so large it's greater than PA. this is the scary thing about being stabbed though. If I actually did get stabbed in the chest, I get 20, 30 breaths. I get 20 to 30 breaths before I can't breathe anymore. So I'm walking away and then I realize that I can't. Okay. What do you guys think? How would we fix this?
We have to make like put a tube in the chest cavity to drain the air, make PIP go back down.
Agreed. So what you're telling me is how to fix a stab wound is to create another stab wound.
But put a straw in it this time.
Yeah, I just think this is one of the ironies of medicine is how do you fix the problem? Well, you stab them again.
And those lungs just are not inflating at all. So it's really tensioned.
You do a needle
Would
decompression
you
now,
like to do a...
or finger thoracotomy.
Go on, you do a finger thoracotomy on this bag and see if we can relieve some pressure. Got a little hole there.
And now the lungs can inflate.
Can inflate the lungs. It's quite a tiny hole you made there, so it's still a bit hard to inflate the lungs, but certainly easier than it was before. So maybe enlarge that hole a little bit. There it is, just on the side there.
Finger thoracostomy.
There we go. And we can re-inflate those lungs.
Cool. So hopefully those videos kind of help you guys kind of realize what's going on there with the pneumothorax. So with that tension pneumothorax, you guys saw it was that one-way valve, right? Air was getting in, but not coming out. So we have to relieve that pressure. We have to prevent PIP from getting bigger than PA. Okay. All right. So let's take a little break here. When we come back, it's pretty much going to be running through the pathologies. But yeah, so let's say, I don't know, you guys, it might have to be a little bit shorter. So like 10:57, we'll pick back up again. Okay. All right. Cool. So on this slide here, this is just going to be vocabulary. Okay, nothing too crazy from it, I promise. Transsudative effusion. This is very similar to serous exudate. What do you guys remember about serous exudate?
It was like clear fluid.
Clear, watery blood plasma. Okay. So it's very akin to serous exudate. Okay. Exudative effusion. This is like your purulent exudates. So i.e. your dead neutrophils. And if someone is producing exudative effusion or purulent exudate, what does that indicate?
Infection.
Perfect. Infection. In fact, exudative effusion and epima, these are the same thing. Okay, same thing, two different words, same thing. Hemothorax, this is blood. Pretty straightforward. Cryothorax, you don't need to worry about, that's lymphatic fluid. That's from a GI obstruction. Okay, what we're talking about with these fluids here, this pleural effusion, this is fluid around the lungs. So be careful here. If we say a patient has transsudative effusion, it's not fluid in the lungs, it's on the outside of the lungs. Now I want you to imagine if you have fluid outside of your lungs, how does that affect your lungs' abilities? How does that affect your lungs?
They also can expand.
Reduce lung expansion. Very good. So what kind of breathing pattern would you anticipate with a patient with epima? What kind of breathing pattern would you expect?
Shallow.
Shallow, yeah. Yeah, so that would be your bradypnea. Okay. All right, so I'm just showing you again, fluid outside of the lungs, not in the lungs. Okay. So in this case here, that's blood. Flail chest. Flail chest is also known as paradoxical breathing. Okay. So if I asked you to take a deep breath, if you were to inhale right now, what would happen to your chest cavity? Would it get bigger or smaller?
Bigger.
Bigger. With flail chest, during inhalation, the chest is sinking in. That's why we call it paradoxical. So let's think during inhalation, which pressure is the largest during inhalation?
PB.
Yeah, it's bare minimum.
PB. Yeah, agreed. In fact, PB must be bigger than PA. That's why your chest sinks in. So with flail chest, I'm either missing ribs or my ribs have been broken. I go to inhale and my chest sinks in. Okay. So what we're saying here is that PB is still larger than PA, which is still larger than PIP. So have your pressures changed with flail chest? No. PIP is still negative. Okay, so with flail chest, your PIP is still negative, your pressures are still the same, your chest is moving in the opposite direction. Think about exhalation. If I asked you to exhale and you close your mouth, your cheeks would puff out because PA is larger than PB. PA is larger than PB, which is still larger than PIP. Okay. Cool. So barreling through. Smoking, it's bad for you. I didn't know if you knew that or not. Why? So with smoking, what we will do is we will sacrifice our type 2 pneumocytes. You'll sacrifice your type 2 pneumocytes. Does anybody remember, what do your type 2 pneumocytes do?
Do they secrete surfactant?
They make the surfactant. Nice. So let me say smoking. It's going to cause a decrease in your type 2 cells. That means we will have less surfactant. 4 functions of surfactant. What are they? Give you guys a break on this one. Okay. Consequences of the decrease in surfactant, we will see increase work. Actually, let me kind of scoot this over more. Oh, God damn it. Increase in the work of breathing. So if I start smoking, does it become easier or harder for me to breathe? Harder. Why?
Because there's less lubricant and there's an increase in surface tension.
Perfect, perfect. That's exactly how you guys should be thinking about this. It's harder for me to breathe because I have less surfactant. There's more surface tension. Okay. We're also going to see increased respiratory tract infections. Why am I now all of a sudden having all these respiratory tract infections?
Because less surfactant
You're good.
I know how it works in my head, but it acts as like a barrier, right?
Yeah, the surfactant is a secretion, i.e. less IgA. Yep, that's your barrier. This is what I was saying, like, hey, you should probably know those functions, right? I'm also going to have increased rates of pneumonia because of those infections, but hey, I can't repel water anymore. And I'm also going to see alveolar sacs collapse. Anybody remember what that was called? When my alveolar sacs collapse, leading to a partial lung collapse. Atelectasis. Remember that partial lung collapse? Okay. So just using this here as a way to say like, hey, surfactant is kind of important, 4 functions, 4 consequences if you don't have surfactant. Okay. We're just going to skip pneumocanosis. Don't inhale asbestos. It's bad for you. Duh. Allergic alveolitis and hypersensitivity pneumonitis. These are the same thing. Okay. So this is when your alveolar sacs become inflamed because of an allergy. What hypersensitivity is associated with allergies?
Type 1.
Type 1. Nice. All right. ARDS, acute respiratory distress syndrome. Acute lung inflammation and diffuse alveolo-capillary injury. All right, what's going on with ARDS? ARDS is defined as an acute onset of bilateral chest infiltrates. Infiltrates is another way to say fluids. Okay. So put this together. ARDS. This is when lung inflammation causes your lungs to fill with fluid. If your lungs are filled with fluid, how does that affect your ability for gas exchange? That's why we see the hypoxemia and the hypoxia. Okay, so kind of walking you through this. This is actually kind of directly important because of COVID. COVID leads to ARDS. Okay, so this is what I've been personally freaking out about. I don't know about you guys, but every quarter with Patho, I become more and more of a hypochondriac. Okay, so here's your alveolar sac. Your alveolar sac is surrounded by its own capillary bed. Cool. Underneath normal circumstances, you have oxygen. And where does oxygen want to go?
Into the blood.
Into the blood. And CO2. Where does CO2 want to go?
Back out into the environment.
Perfect. Out of the blood into the environment, either way you want to say it, right? The issue is once we have inflammation. The issue is when we have inflammation. Now, you guys remember with inflammation, there are two effects. What happens with inflammation?
You release histamine.
And that has what two effects?
An increase in capillary permeability.
Nice. Vasodilation and increase in my capillary permeability. So my capillaries become more permeable. Fluid is going to leak out of the capillaries. So this is what we're talking about with that bilateral chest infiltrates. That's fluid. And that came from your dilated blood vessels. So CO2 no longer can leave your blood. Oxygen can no longer go into your blood. Basically, with ARDS, your lungs fill with inflammatory fluid, causing a person to drown. Okay. Now, directly tying this to COVID and why this is so freaking crazy. Patients with COVID with, immune systems who aren't ready for it or whatever. We can see this process happen within 8 hours. Somebody's lungs can completely fill with fluid within give or take 8 hours. Okay, this is not something I would even want on my worst enemy, because you're gonna feel the fluid build. You're gonna feel this fluid in the lungs build, and it's gonna become harder and harder to take a breath. Okay, each breath is gonna be such a struggle. Okay, let's also kind of think about this here. Which one takes energy, inhalation or expiration?
Inhalation.
Inhalation, because of the diaphragm, correct. With ARDS, your capillary membranes leak fluid into the alveolar sac. This is a common ICU complication because of what's called tiring out. Okay. When a person, quote unquote, tires out, the diaphragm can no longer contract. Okay. This is personally for me what is terrifying, and I wish more people kind of knew about this. As the lungs are filling, this person is going to be gasping for air. They're going to be working that diaphragm. That diaphragm is a skeletal muscle. The more you work skeletal muscle, the more sore, the more fatigued it gets. When a patient tires out, they don't have any more energy in their diaphragm to inhale anymore. This person is drowning. They are aware of it, and they can't even muster the energy to breathe. This is why we need ventilators. Okay. Terrifying, absolutely terrifying. Okay. Sorry. Causes wise, pneumonia, burns, and disseminated intravascular coagulation. We're going to talk about disseminated intravascular coagulation a week from now, so just hang tight on that. Okay. So here, just kind of pulling it together. Why do we need a ventilator? Why do patients need a ventilator with ARDS?
Because their diaphragm tires out from working so hard to breathe due to the fluid in their lungs.
Perfect. Diaphragm tires out. And if we take an X-ray, why do their lungs appear white?
Because there's a lot of fluid and infiltrates in there.
Nice. Infiltrates. Okay. So really that's kind of two things about ARDS. You need a ventilator and you're going to be filled with fluid. Okay. I don't know. This one, nothing really too crazy. I'll just say moving a line through it. Obstructive pulmonary diseases. One thing, what these three have in common is that it is worse with expiration, i.e., it is harder to exhale than it is to inhale. Okay, it is harder to exhale than inhale. Asthma. Now, there are several different types of asthma. We're only going to be talking about allergy-related asthma. We're going to see difficulty with inhale and exhale. Okay. Emphysema and chronic bronchitis, these two will have difficulty with exhale. Okay. And let me say both will lead to COPD, chronic obstructive pulmonary disorder. Let me give you guys a heads up. Emphysema, chronic bronchitis will lead to COPD. That's going to be a quiz question. Okay. Something along those lines. Okay. So asthma, again, we're only talking in relation to a type 1 hypersensitivity. You guys have seen this picture plenty of times before. Okay. And what's causing the narrowing of the airways with asthma, type 1 hypersensitivity?
It's histamine release.
Perfect. Histamine. Okay. This can lead to status epilepticus. It's really fun to say. Status epilepticus is just known as an acute bronchospasm. So that's why if the airway is narrowing, it's difficulty with inhalation and expiration. With chronic bronchitis, you need to know the definition of chronic bronchitis as the hypersecretion of mucus and a productive cough. You don't need to know the timelines. That's kind of out of the scope of our practice here, okay? But with chronic bronchitis, this person is producing way too much mucus, way too much mucus. In fact, this mucus is thick. This mucus is thicker than normal, okay? So like 3 C's. What would cause a person to produce so much mucus? Think about in your life, when have you produced a lot of mucus in the respiratory tract?
When you're sick.
When you're sick. So with reoccurring infections or inspiring irritants. What kind of irritants are we talking about that can cause chronic bronchitis? What would someone be inhaling every day multiple times?
Tobacco smoke.
Yeah, tobacco smoke or particulates or pollution. The other thing I can think of is like a house fire. You inhale a lot of smoke that way. Okay, so chronic bronchitis, too much mucus, it is way too thick, caused by reoccurring infections or these inspired irritants. Okay. So problem is, hey, you produce a lot of mucus. So what? This is the problem. When you inhale, your chest expands or contracts? Expands. So when you inhale, notice your airways open up. You got this mucus here, no problem. When you go to exhale, your chest contracts, closing down now. This right here is called a mucus plug. Maybe not use blue. That is a mucus plug. So this person goes to exhale, they can't. Again, this is why they have difficulty with expiration. Okay, this is a form of what we call air trapping. They just can't get that air out. So what were they trying to breathe out? What gases were we trying to expire?
CO2.
Yeah, CO2. Nitrogen's in there as well, but mainly CO2. So what's building up in their body?
CO2. Acid.
CO2, and that leads to acid. Now remember, this is the lungs' inability to get rid of acid, or the lungs' inability to get rid of CO2. So that would lead to respiratory acidosis. So just kind of tying it all together here. You don't really call them blue bloaters anymore. This is more of a teaching exercise. Don't just call someone a blue bloater. That's kind of mean, right? Why are they cyanotic?
Because they can't get enough oxygen to their body.
And they're building up that CO2. Absolutely. So it's, let me be clear here. The symptoms that I'm underlining, those are the ones you guys need to know. Okay. So we had that recurrent cough with that sputum because of all that mucus. Okay. They're building up that CO2, that hypercapnia, has that respiratory acidosis. Okay. And digital clubbing. So yeah, and also smoking next to oxygen, always a great idea. Don't. All right, emphysema. So remember, chronic bronchitis and emphysema, kind of two sides of the same coin here. This is where we have destruction of the alveolar walls without scar tissue. I.e., we have this loss of elastic recoil. We can't return to original size/shape. Excuse me. So somebody with emphysema, they go to inhale, no problem. But their lungs don't contract back. Their lungs don't recoil back. So what do they have to do? What muscle do they have to use to force expiration?
Rectus abdominis.
Have to use the rectus abdominis. Again, we're also seeing air trapping here. Because for two different, so we're seeing air trapping for two different reasons. Chronic bronchitis, it was the mucus plug. Here, the air is trapped because their lungs don't snap back. They have to push it out. Okay. So here's along with emphysema, icky, gross. We used to call them pink puffers. Again, just don't. They're not blue despite having increased CO2. So they have minimal cyanosis. Again, it's not because the CO2 is like trapped in there by some foreign object. They actually have to work harder. Think about when you work out, when you exercise, what happens to blood flow? Goes up. That's why they're more pink than anything. Pursed lip breathing. You too can get those Kylie Jenner lips. Just start smoking. Why? Why would you start getting this added lip filler without lip filler? What kind of face do you make when you blow out candles on a cake? This is what they're doing. They have to purse their lips so they can get that air out. That's why their lips become pursed. You'll see hyperresonance on chest percussion. That's for a health assessment. You're going to hear hyperinflation. Okay. And you'll see barrel chesting. Okay. All right. So pneumonia. Relatively speaking, there are two types of pneumonia. You have community-acquired pneumonia and hospital-acquired pneumonia. Now, this is a very popular foundations question. I know you guys aren't there yet, but just hang tight. Which one's more dangerous, community or hospital-acquired?
Hospital.
Hospital? Anyone agree, disagree? So actually, this is why it's such a popular question. Community is actually more dangerous. Okay, let me paint you a picture here. Anybody work in the hospital currently? Okay, so if you work in the hospital and I walk into the waiting room and I have pneumonia, what do you do instantly?
Oxygen.
But even before that, do you want me just hanging around the other patients?
Oh no, we take them to the back.
Yeah, you isolate me. You put me in the back away from everybody else. Versus hospital-acquired pneumonia, if I've been in the hospital and I develop pneumonia, do you instantly isolate me?
No.
It takes maybe about a week. Why? What I'm getting at here is community-acquired pneumonia means you got it from somebody in the community, right? Which means you know that this is contagious. Hospital-acquired pneumonia, yeah, it could be viral, it could be contagious. It also could be because you didn't turn me every 2 hours. It could be that I just had chest surgery. It could be that I have fluid overload. Hospital-acquired pneumonia takes time to dig it out. Versus if I walk in with it, you know I got it from somebody else. Does that kind of make sense? That's why community acquired is considered more dangerous, because you know it's contagious. Pneumonia, tuberculosis. Oh, all right, tuberculosis, super bad. Why? It causes your lungs to rot. Okay, it causes your lungs to rot, and oh, it is highly contagious. Spread through the air. Sorry, I know it's already 11:30, so I'm going to kind of like blow past this here. So tuberculosis, highly contagious, causes your lungs to rot. Hey, it's necrosis. Are we coming back from this? No. I'm going to skip that. Croup. Okay, croup is going to be an upper respiratory tract infection that commonly hits kids. Because their immune system is not as good as yours. Okay. How do we know that it's upper? When they cough, they have a barking cough or crowing sounds. If you ever heard a kid with croup, it's terrifying. You can hear them outside of the hall. Okay, because that's affecting their larynx, their voice box. You know it's an upper respiratory tract. Pulmonary embolism. Pulmonary embolism, i.e. a PE. Basically, it's a thrombus or an embolus or anything, tissue fragment, air bubble, it could be fat, could be even cancer, that goes and causes a blockage in the lungs. So let me say a clot that gets lodged in the lungs. Okay. How will this affect your VQ ratio? I think V over Q. This is a clot in the bloodstream.
The blood flow is going to go way down. So the V ratio is going to go up.
Yep. So pulmonary embolus will increase your overall VQ ratio, correct? We can skip all of the classifications. Okay. Pulmonary hypertension, we kind of talked about. All right. So this slide here, I want to kind of make sure we get to. This is the last important one, I promise. Cor pulmonale is a heart disease where we see right ventricular enlargement / failure. What? Why are we talking about the heart all of a sudden? So you don't need to draw this diagram yet because this is the diagram we're going to start with on Tuesday, so tomorrow. Just drawing it so you guys can see it for now. If I have some problem in my lungs, like a traffic jam, what chamber does that back up into?
I'm really sorry. Can you repeat that?
Yeah, so if I have a problem in my lungs, which chamber of the heart does that back up into?
The left ventricle.
It would be the left if you're looking at it, but because we're drawing the heart, it's weird.
Right ventricle.
Mm-hmm. Okay. This is usually secondary or caused by pulmonary hypertension. Pulmonary hypertension. Okay. Does anybody remember what caused the pulmonary hypertension?
Shunting caused by hypoxia.
Shunting caused by hypoxia caused that hypertension. So this is why I was saying, going back to this picture here, we have this pulmonary edema. That's going to lead to right heart failure. This is the tricky part about exam 3. What affects the lungs will also affect the heart. Now, what caused the hypoxia? It could be anything. It could be any of the respiratory pathologies. Respiratory patho. Okay, so your respiratory patho, chronic bronchitis, emphysema, tuberculosis causes the hypoxia, which causes shunting, increases capillary hydrostatic pressure, increases VQ ratio, can go all the way and affect your heart. So that's where we're headed. Okay, that's where we're headed. We're going to explore this when we start talking more about cardio, but this is the key to exam 3 right here. So I'm sorry, this class took a little bit longer, guys.